Right. Our last lecture for the cardiovascular system consists of looking at chapter 21 in big overview style by looking at blood vessels and how they correlate to the circulatory system and the circulation of the blood as pumped by the heart, which we've already talked about. So we have a couple different types of blood vessels. We've already mentioned them, so we'll recap that. Obviously, we have our pulmonary vessels that we've already talked about as well. And those are some of our larger vessels, right? The pulmonary trunk coming out of the heart, going into the lungs, and then the aorta, obviously the largest artery in the heart, strongest and providing the most amount of initial blood to the other arteries that will then branch out. So just as a recap, remember, we start with blood coming away from the heart. That's oxygenated blood, right? So this is kind of our flow chart or pathway. So we would say we start at the arteries, and they're always going to carry that blood away. Those arteries are going to make their way into the rest of the body, and then they are going to get smaller. And we refer to those smaller arteries as arterioles. Those arterioles then are going to get lead into and essentially get tinier and become what we refer to as capillaries. And we'll take a closer look at those a little bit later. And they basically have extremely thin walls. And the purpose of a capillary is to do the actual gas exchange, to do the nutrient exchange, the waste exchange, etc. On the other side of the capillary bed, we have the smaller veins. And those are the smallest branches of those veins that are going to be carrying that deoxygenated blood as part of the venous return system to get back to the heart. And then those smaller venules are going to merge together and then finally become veins. And those veins are then going to make their way to either merge into the coronary sinus, or if they're in the heart, or merge to the superior inferior vena cava to return that deoxygenated blood to the right atrium of the heart. In terms of blood vessel structure, there are a few different layers in which we find in the different blood vessels. And the first is the inner layer, and that's called the tunica intima. Tunica meaning layer, intima meaning inside. It is an endothelial layer, basically connective tissue, and it's going to provide us with some elasticity, especially in arteries. And we're going to see why we're going to need that in a minute. The next layer is called the tunica media, or the middle layer. And this is where we're going to have that smooth muscle. All right. It's going to be surrounding what we refer to as the lumen, or the open space in the blood vessel, which is where the blood is going to move. And again, you're going to have that elasticity here as well. And then lastly, you have the outer layer, or the tunica externa. And that basically is going to provide an anchoring of the vessel to whatever other tissues it is interstitially. And you can see, again, the elasticity present in that tunica layer. And then we will see some smooth muscle if we are talking about a vein as well. So here, let's just take a peek. This is what we're going to look like if we are an artery. So make sure you can identify these structural differences. So you can see here on the diagram side, there is our external layer, or tunica externa. All right, and there's we've got the collagen and the elastic, and again, that anchoring to whatever interstitial tissue we have. You can see the very thick layer of tunica media, so lots of smooth muscle because we want to generate high pressure in the artery, right? Because we're trying to get that oxygenated blood out into the body. And then you can see the very small, thin tunica intima. And again, this would be the lumen. So here you can see an actual artery. You can see the very thick tunica media, and then the lumen where the blood would actually flow. You can also see a vein here simultaneously, and let's jump to that diagram. And you'll notice some structural characteristics that are different. So obviously, we still have our tunica externa, so we have that anchoring layer. But notice that the tunica media is significantly smaller, so that you have definitely less smooth muscle there. And again, that's because you're not trying to generate as high of a pressure. It's not as urgent to get that oxygenated blood out. And then we have the tunica intima, again, facing the lumen side. And so you can see the difference between the vein and the artery from that microscope view. You can see here listed some of those differences, some that we've already talked about, and a couple that we will see momentarily. So again, the thicker tunica media in the arteries obviously results in that allows for that higher pressure within the arteries. The lumen for an artery is much smaller and much more rounded compared to the vein, which has that very large and irregularly shaped. Let's jump back here so we can see that. pretty fairly rounded. And then again, that kind of larger lumen or irregular shape. You do have some folds in a constricted artery. We're not too concerned about that. Key piece here tied to the high pressure is that arteries will be more elastic than veins because they need that elasticity to survive the higher pressures that they're creating. And then lastly, which we'll take a look at a little bit later, is that veins have valves, valves. And that's really important for backflow issues, especially coming from the lower limbs. And we'll take a peek at those as well. So a couple of terms to be familiar with, especially when talking about arteries and their control, especially lots of medications that we've talked about already for a lot of our cardiac diseases, are two concepts called vasoconstriction and vasodilation. So vaso, anytime we see that prefix, it just refers to vessels. And then constriction, obviously meaning the contraction of that smooth muscle in the arterial wall. Dilation, meaning the relaxing of that. And that would obviously result in a larger lumen. So if I have high blood pressure, I'm going to want to take some vasodilators because that's going to allow for my lumen of my artery to be bigger, blood to flow a little bit freer, and the pressure to drop down. Obviously, vasoconstriction would happen if we needed to increase that pressure for whatever reason. So maybe during some type of hormonal response or stress response, some type of illness or hemorrhage, etc. That might be necessary as well. Something that can happen, especially with hypertension, and we'll go through this as well, are aneurysms. You may have heard the term before. And basically an aneurysm is kind of like a little ballooned portion off of an artery that's just kind of like a blister that's expanded out that arterial wall. And essentially it's resulted in a weak spot in the elastic fibers of those tunicas. And basically you have that kind of blister. And as we know, blisters can kind of pop at any time. And that's basically what can happen in an aneurysm, especially if the pressure continues to be high in that particular artery. And then when that bursts, obviously, depending on the location of that aneurysm, that could be fatal or it could not matter at all. So you have a wide range of consequences based on where that aneurysm is actually located. Obviously, cerebral aneurysms and abdominal aortic aneurysms are probably two of the most common aneurysms that we encounter. Here's just a visual for you. I would recommend using this as a study tool so you have them side by side to kind of compare out your various layers, the different elasticities present, again, more in the arteries than in the veins, the thickness of the tunica media compared to the thinness of that in the artery compared to the vein. You can see size difference as we get smaller and smaller, right? Down from our largest vein or artery into our kind of medium size into our smallest. And then, oops, sorry, I brought that up at the bottom. You can see the capillaries at the bottom, basically a tissue paper, a thickness of like a single red blood cell being able to allow for movement across that membrane. It's definitely a good study image there. And there's just another close-up of those capillaries. I think that would be helpful, again, just in comparison to the arteries and the veins, which obviously have those multiple layers for thickness purposes. So why do we have capillaries? Why do we get down to this smallest layer? Because we have to do exchange. All right, capillary exchange is fundamentally why we are pumping blood, is so that we can do that gas exchange. We can get oxygen so we can make lots of ATP and we can have lots of energy to do things and be multicellular organisms and multi-system organisms that we are. So in addition to that gas exchange, we are also going to have movements of nutrients as well as gas, or obviously gas, but waste products that are going to move across that membrane as well. So as you can see, the structure of a capillary is very basic, very, kind of pared down, a thin layer. It's basically endothelial cells, very thin layer of them. You don't have any smooth muscle in there. You don't have an external anchoring layer. The diameter, the thickness is very, very, very slim. And so this is what looks like at a capillary bed. So when we've reached that point where an artery, an arteriole, I should say, tapers off into this very small section, and they're going to branch into these capillaries, and they're going to be embedded and weaved through whatever organ, tissue, bone, muscle, whatever it is that we are talking about in the body. And we'll have these capillary beds that sit throughout. And basically, as the blood moves through the capillary bed to the other side, which is going to be the venous side, the gas exchange and the nutrient exchange is taking place because we have the high to low concentration differences as well as some potential facilitated diffusion there. When that blood makes its way to the venous side of the capillary and heads into that venule, a very, very tiny vein, we can see that we've notated it with our color difference, right? Our red indicating our deep, dark, oxygenated blood, and the blue color indicating that that very, very dark, deoxygenated red blood color, easier to differentiate if we use blue. And so we are going to then merge back up into much larger veins until we get to veins that are going to return our blood to the heart. Again, notice the unidirectional flow of blood is unidirectional throughout the body, not just when we're talking about it within the heart. And then this is just giving you a light microscope view of the same image. So you can see that arteriole then branching in to the capillaries. You can see that arteriole came from a smaller artery that was branching off, and then those capillary beds will move into the venous side, and then we'll return back up to the heart. A couple of differences that we should make note of for the vein side of the vessels are veins, remember, are going to collect that blood. They're on the other side of the capillary bed, and they're going to return that blood to the heart. So here are your three main differences between veins and arteries. Obviously, the pressure is significantly lower in a vein than an artery, and that's due to those thinner walls. We don't have the muscular layer there. We don't have the decreased space in the lumen, and their diameters, their lumen space is going to be much larger. And that's so that we can get a lot of blood up without having to increase the pressure. One thing that veins do have that arteries do not are valves, all right? And within the folds of that intima layer, so within that layer that is directly in the lumen or surrounding the lumen, you have these folds. And basically, their job is to prevent backflow of blood. So much like the valves in our heart, like the aortic semilunar or the pulmonary semilunar, they allow for that blood to be prevented from moving back. And this definitely helps, especially in your lower extremities, as the veins are working against gravity, but they have low pressure. So they need every help they can get to stop that blood from just draining back down to your feet. Sometimes those valves, though, can get weakened, especially people who are on their feet a lot, and maybe they're either on their feet a lot, just period, or they have maybe some extra weight on their bodies and they are on their feet a lot. That can result in a weakening of the valves so they don't close all the way. And then we end up with what's called varicose veins, meaning that those veins essentially are going to have broken capillaries, and you're going to have blood that's going to pool there because you're not going to be getting that good blood flow. And so you're going to have that kind of buildup of fluid in those areas, which obviously is not good for your lower extremities. And here you can see a closed valve versus an open one, and the purpose of having them again is so that blood, coming down from our lower extremities can kind of make their way up as we see muscle contraction in those lower limbs, and then get the blood back up into the superior inferior vena cava and into the heart. All right, in terms of where we've got most of our blood, as you can see, the majority of your blood actually is spending its time in the venous system. All right, and notice that even of that, almost 70% of your blood at any given time is going to be in that venous system. 1/3 of that is actually going to be in these three areas: your skin, right, our largest organ, our bone marrow, and then our liver. Our liver, but we'll be learning, is our major filter, our filtration system in our body. So that makes a lot of sense that our blood's going to spend some time there before it makes its way back to the heart. And this gives you a nice little breakdown of kind of where our blood is spending its time at every given moment. And just again, recognizing that the majority of your blood is going to be during that return phase, is heading back to the heart to then get back oxygenated and then pumped out again. The other major topic that we want to mention for this unit is blood pressure. So again, a very brief overview. There's a bunch of different pressures in the body. We're primarily going to talk about arterial blood pressure. There's also, as you can see, others, but arterial blood pressure is the one that when you have somebody take your BP, your blood pressure, that's what they're taking. And they're actually taking two pressures. They're taking a systolic and a diastolic. And if we remember from earlier in this chapter, systolic pressure refers to contraction. So this is the pressure or the peak arterial pressure, so the highest pressure when your ventricles are in systole or when they are contracting. And then diastolic pressure is the lower or the lowest arterial pressure at the end when the ventricles are relaxing. So when you are taking blood pressure, you are actually listening for some sounds of some blood flow flowing in the arteries, and you are reading two numbers. The first number is the systolic pressure, so it's always going to be a higher number. Typically in an average adult, that's 120 millimeters mercury. And then you're going to read the second number, and that is the diastolic pressure. And typically that is 80 millimeters of mercury. But again, you can have a wide variety of that, not too wide, but you can have a range in there of where you would be, and depending on your age, your sex, your dietary and physical activity levels, and a whole bunch of other factors. That blood pressure will be very different depending on you in particular. There you go with that 120 over 80. And then obviously our two types of blood pressure that we could have if we have abnormalities: hypertension, meaning we have high blood pressure, and that's when it's consistently above 140 over 90. So obviously when you are doing some type of activity level, or maybe you're undergoing some type of stressful situation, your blood pressure may go up, all right? But if it doesn't say sustained that high, you don't have hypertension, all right? Sustained pressure, and that could be your systolic or your diastolic number. Systolic being over 140 and diastolic being over 90 consistently. You're said to be kind of in the early phases of high blood pressure if even your systolic is at 130. So that range for what could be classified as hypertension is definitely getting smaller. And then hypotension is low blood pressure. So again, that would be something that for a decent amount of time, your blood pressure was sustained low. And that could be during a surgery, that could be due to hemorrhage, could be a lot of things, extreme cold, all of those. One of the factors that influences blood pressure is the elasticity of arteries, as we've already mentioned. They are very elastic in their nature and have a lot of those collagen elastic fibers. And basically that stretching during systole or contraction allows for a pressure buildup, because we can stretch and then we can recoil, and that process results in the maintenance of a high blood pressure in our bodies, and that's very important for moving that blood out and about into the body. On the flip side, you also do have a venous pressure, part of that venous return system. It's very low resistance, again, due to that very large lumen, and it's very low pressure, but it is still there. We do need some type of pressure to move the blood throughout our body, okay? Now, once we've used that pressure to get things there, here's a few reminders about what's happening during that capillary exchange. And you can read through this in a little bit greater detail if you wish. But again, remembering that it's not just gas exchange that's happening during capillary exchange. There's fluid movement, there's nutrient movement, there is waste movement. And you can see here, it is a complicated process of which we are not going into in this class, but you definitely want to kind of reflect on this idea, especially as you move forward into your further anatomy classes, right? Another term, because you'll hear about it in the live heart surgery, is something called perfusion. And perfusion basically has to do with how well is your blood flowing to the tissues in your body. So there is a person who's in the OR during a heart surgery that's called the perfusionist. And their job is basically to monitor to this process. So we want to make sure that your tissues in your body are receiving oxygen and nutrients, all right, all of them. And we want to make sure that the carbon dioxide and the waste are getting removed. And you can see there's a few different factors that can influence that. Obviously, how healthy and how productive your cardiac output is in your heart. Obviously, the resistance that is being met in those vessels as we head into the different tissues of our body, and then obviously your blood pressure as well. So when we talk about that movement of blood flow, that perfusion, obviously vasodilation can be important for that. So if we need to get more blood flow to those tissues, vasodilating or making the space within the lumen of the artery bigger is definitely important. And there are numerous types of vasodilators that are located within your body naturally, that are hormonally controlled or chemically influenced. And obviously there are ones that you can take as medications as well, all right? One area I would like to mention, though we'll talk about it again with the nervous system, is that your brain is greedy when it comes to blood. It is the top priority location for blood flow because your brain has the highest oxygen demand in your entire body. And so it's very important that your brain receives oxygen. So that's why limiting oxygen to your brain can be so devastating. If you have some type of rupture or damage to a cerebral artery, so an artery carrying oxygen to your brain, that we refer to as a cerebrovascular accident, or a CVA, more commonly referred to as a stroke, that means that blood flow to the brain is stopped. So the longer that stoppage occurs and the area of your brain in which that occurs, the more severe and detrimental that can be. And that's why stroke patients can have lots of different effects based on the resulting stroke. Your heart, your lungs, and other major organs also require blood in significant amounts to maintain functionality. And again, if you were to think, what are your top 3 organs? Brain, heart, lungs probably would be in that top 5 that you would mention. So they're all going to have some major oxygen demands. Obviously, we know that our cardiovascular system is going to respond to exercise in a variety of ways. So we're going to change based on our vasoconstriction and dilation. So just based on the smooth muscle in our blood vessels. We're going to change based on hormonal influences to our heart rate, based on outside factors that are resulting in those changes. And then you can see just in terms of kind of what that blood flow, how that blood flow changes. So, at rest, our muscles are only getting about 1,200 milliliters per minute. If we're doing something, running a marathon, or we're playing some type of doing high level cardio or something like that, you've massively increased that amount of blood flow. So just keep in mind the changes in cardiac output, right? From a little under 6,000 milliliters to almost 17,000, 18,000 milliliters per minute, depending on the needs of the body during that exercise, okay? A couple of things here as we head into the last piece-ish to talk about in this unit is taking a look at some arteries. So we're not going to have you identify all of the arteries. There's just not the time. But do familiarize yourself with some of these major arteries that you are seeing here. Obviously, the ones we've already talked about, the aorta, both ascending and descending or abdominal. You can see some major arteries going into the head. So again, those carotid arteries are very important. You have cerebral arteries up here, coronary arteries here. You have arteries that go to your kidneys called renal arteries. You have arteries that go to your liver called hepatic. You have femoral arteries that go into your legs. So you have brachial that go into your arms. So you'll notice that those regional terms really help to identify, where those arteries are located. And it's always a good idea just to kind of go through those. I will mention a couple in class that you will be required to know as well. All right. There's just some of the images, some of the cerebral arteries that I talked about, that if they were to have a blockage or they were to get damaged, that could cause one of those CVAs or those strokes. And then the flip side, taking a look at some of those veins. So again, the veins we've already talked about, pulmonary, superior and inferior vena cava. Those would be your majors. Obviously in our neck, we have jugular veins that are located there. Again, the flip side of all the ones I've mentioned, brachial, femoral, renal, etc., based on the region of the body. One other vein I would mention is that you have, I don't know if we've got a posterior view of this, so we won't be able to see it, but we'll talk about, yes, we do, perfect. The one vein that I would have you know in the leg is called the great saphenous vein, and that runs down here. The majority of your leg, that is the one that during a coronary bypass, they are usually going to extract out and use as part of the actual bypass around the occluded artery. So that would be definitely one, in addition to our vessels attached to the heart, that you want to know as well, okay? Last thing to mention here is that as we get older, like with every other system, things change, all right? So in our blood, we tend to have poor circulation in our extremities, especially in our lower limbs. So we tend to have fluid buildup there and decrease in our blood cell counts. We have changes in our heart, so cardiac output starts to decrease, elasticity within our cardiac muscle and skeleton starts to decrease. Obviously, the likelihood of more occlusions or plaque buildup is definitely higher up there. And as if your cardiac muscle it gets damaged, the replacement of that usually is scar tissue versus replenishing cells. And then in our blood vessels, we can see the elasticity starts to drop. We start to have calcium deposits sometimes in our vessels, which can lead to blockages. So that's a risk for stroke or a heart attack, myocardial infarction, depending on where it's located. And then blood clots. Blood clots can make their way into the blood vessels and detach. That's called a thrombus. And that can make its way into a smaller artery and then create a blockage. Again, depending on where that's at, that can result in a stroke or an MI. So that will conclude our cardiovascular system.